Welcome to the second session of this ICPerMed conference. The session is Enhancing Life Science and Health-Related Data through Biomedical Research, Data Harmonization, and Regulatory Frameworks. Indeed, the use, harmonization, collection, mining, and security of data represents an overarching topic, as we just heard in the session before, and is one of the pillars that was identified in the ICPerMed vision paper. To get the feedback from you as audience, you will find again, well, this time 4 questions even, to this data-related topic. So please look on your right side in the interactivity section. We are having, well, the first question, have you had your genome already sequenced? Would you be willing to share your genomic or health information? With whom you would be willing to share your genomic and health informations? What is the most important use of data for personalized medicine application? So please have a look and send us your feedback. And it is my great pleasure to welcome the moderator of the session, Professor Alfonso Valencia. Alfonso is the director of the Life Science Department in the Barcelona Supercomputing Center and director of the Spanish National Bioinformatics Institute. Thank you, Alfonso, for your help in the scientific committee, and thanks a lot for moderating the session. The floor is yours.
Thanks very much for the introduction. It's a pleasure to be virtually in the meeting, even if it's only virtually. So we go ahead with this section on data. We have 2 speakers that will cover, I would say, the 2 streams, from the data organization and the standards to the data analysis and what we can get from this type of data. Let's start with the first talk. Peter Goodhand. He's the CEO of the Global Alliance for Genomic Health. He will explain this better than me, but it's an extremely interesting organization and movement to create standards and ways of working with genomic data that has taken an enormous speed over the last few years. And we are all depending on how this organization moves. Previously, Peter has been CEO of the Canadian Cancer Society, that is the largest health charity in Canada, and president of the Ontario Cancer Research Institute. So he has, as you can deduce from that, a large experience working with health organizations, charities, and all the constructions around cancer, from the patients to the research, and now with the Global Alliance. So Peter, thanks very much for being here today, and we really look forward to this.
Thank you, everybody. This is a great opportunity for you. If you were part of the earlier session, you would have seen me wearing a different hat, my patient perspective. This perspective is as the CEO of the Global Alliance. I will keep it at a very high level. We'll go through it quickly because I think they want to make sure that we got lots of time for the conversation that will follow. Global Alliance was started in 2013, but we really got up and running in 2014. From the beginning, this mission statement was very emphatic that it was not about bigger, better genomic research. It was about bringing genomic science and research closer to healthcare and making a true impact on human health. It was bringing these fields together. From the beginning, our work has been shaped and based on a framework for the responsible sharing of genomic and health-related data. Owes a lot to Dr. Bartha Knoppers, but she organized a large group of regulatory and ethics leaders from around the world to create this framework, which is a very high-level document. You can see the foundational principles and the aims, but it has also been a root document, and many of the other things we've done in the last 7 years on the regulatory ethics side have come from this essential route, been translated into many languages, and has gone through an update. The framework itself, though, was based on 2 fundamental human rights that are contained in the Declaration of Human Rights. The right to science, so the right of individuals to benefit from scientific advancement, and the right of scientists and others to be recognized for their work. The other key to the perspective we took on this was that we understand that there is harm, potential harm, from bad sharing or inappropriate use, but we also know there's enormous benefit from enabling responsible sharing on an international basis. So our framework was always about creating that balance between protecting people from harm, but achieving benefit for the public good. Today, we're tracking over 200 genomic data initiatives globally. Some of them are grounded heavily in clinical and genomic medicine, many in traditional research. Some are national precision medicine initiatives or regional precision medicine initiatives that bring together clinical practice and research. And then others are in cohorts, whether they're disease cohorts or population cohorts. From a research perspective, though, I said we weren't all about the research, but from that research perspective, if we can enable secondary use of clinical genomic data, we have a virtual cohort that's in the tens of millions within a relatively short time. But more importantly, they will be much more informative genomes. They will have phenotypic information and clinical information that makes the actual genomic sequence far more meaningful as we start to unravel complexities. These will be some of the reasons, not all of the reasons, but we're clearly doing this in the sense that by sharing at a scale and across a breadth of different data sources, we start to unlock and unravel patterns of disease, complexities, nuances that are not obvious if you just look at a few genomes or a single patient population. So we believe it's the breadth and the diversity of this information that can really accelerate our understanding of the genome. But it does mean, as we move from traditional research approaches into a newer way of seeing things, that we have to have multiple different ways of sharing data, of holding it, protecting it, and sharing it. If it is knowledge, then we're trying as hard as we can to get it into very easy, accessible public genomic knowledge bases. The BRCA exchange would be a great example of that. If it's associated with more protected information, we need to maintain privacy and security. We can think about data commons and data safe havens. But increasingly, we are also seeing use of federated approaches, whether they're in a hub and spoke type federation, whether they're in a tightly managed federation, or whether they're more of a linkage of disparate data sets, but using federated methodologies. So overall, I think I got this originally from Baron Mons, but a shift from the concept that sharing previously in genomic world has been, I went somewhere, copied the data, downloaded it to my local environment, and did my research. That data copying. And increasingly, that is not appropriate, either because I shouldn't be taking a copy of the data from a protected site, or that the data is just so massive that that's a very inefficient way of doing it. So increasingly, we're seeing the concept of data visiting. Bring the analysis, bring the query to the data, compute where the data is, and return the results. A different shift, and it's for both jurisdictional reasons and good data science. We do say, though, increasingly, I think when we started, there was almost no genomic data in the cloud. Now it seems to be the default to think cloud, whether it's a private cloud or a public cloud. With the move to cloud, federation is much more of an option. And I think we can see this, the more we get to health data, the more we will have to rely on federated approaches. That data will stay in jurisdictions. And on the genomic side, on the research side, we've got a long history, 20 plus years of international collaboration and sharing. But in healthcare, it's absolutely the opposite. Healthcare is incredibly local and tends to stay within a system. But we've got to find different approaches to bring this data sets together. Just a quick overview of Global Alliance, over 600 organizational members, half of which are industry, represented from 90 countries. We've got about 3,000 individuals either subscribing or supporting us in one way or another. We have 24 driver projects. And they are real-world genomic and health-related driver projects. But our work engine, the piece of Global Alliance that really produces the standards and the protocols, are our 8 work streams. We've produced so far 20 technical standards for data interoperability, 7 regulatory policies and frameworks, and 40 implementations. It could be a lot more. We were not good at tracking how widely our tools are implemented, our standards are applied. Increasingly, though, we're trying to see this not as a linear movement from research through clinical research into healthcare, but increasingly think of it as a learning health system. And from our perspective, how can we enable a global learning health system? Quick schematic, this is the 8 work streams are on the horizontal, 6 of them are technical, 2 are foundational, 1 for regulatory and ethics, 1 for data security. And if I represented all the real world driver projects on the verticals, there would actually be 24 of them, and they cross a wide spectrum. So work streams are inside Global Alliance, volunteer-led, staffed and supported, producing the products of the Global Alliance that drive towards data interoperability. Driver projects external to Global Alliance partnered with us, helping tell us what we should be working on, bringing their own resources, and more importantly, once we've got that, becoming early implementers of the tools that they've helped to develop. These are the 24 driver projects. You can see some span across multiple disease states, particularly the ones that are precision medicine initiatives at a national or regional level. Some are in rare disease, some are just in cancer, and some are in complex disease. So that sense of 24 representative, if we have got this right, those 24 will act on behalf of the 200 plus genomic data sharing initiatives. Increasingly, though, we create these communities of practice. It's no longer just about the work streams and producing the standards, but a focus on implementation. And in that, we've been fortunate to have great leadership from Genomics England, and they've expanded their base, their membership, to talk about an implementation forum. So it means not all of these are helping develop the standards, but they become a community of practice to look at best practice across their things they will get from Global Alliance and things that they would not get from Global Alliance, but they need to work on for the rest of their projects. So this is a new community, it's a strong community, and we're incredibly proud to work with them. I realized as we were talking in the earlier session, and somebody mentioned the strong European perspective of ICPerMed. I should have included beyond 1 million genomes in this slide. But what I was trying to get across here is there are tens of millions of genomes represented by the logos and the acronyms here. And you just a sense of the breadth of groups that are working towards this global collaboration. The one on the top right-hand side that doesn't have a name is the International 100 Cohort Consortium that I co-lead. And that's almost 100 cohorts that may not have genomic data today, but are working towards it in the future. And we're leveraging as much as we can tools and solutions that will be made by one group, making sure that they're applicable or at least available to the other groups. As Global Alliance gets closer and closer to healthcare, though, we also recognize it is not just about the research community saying this is how you should represent, analyze, store your genomes. We've got to work with other standards groups that are established inside healthcare. And you would have things like CDISC or ISO or HL7, and particularly HL7 FHIR. So really incumbent on us now to make sure the interoperability we're building in the research world can actually be mapped and translated into existing standards for healthcare. Talked about a circular system rather than a linear system. This, just to give you a sense of it, you don't always start in the same place and you don't always end, but there is that sense of an interactive system, a virtuous cycle of learning. And we mapped this for ourselves and then started to map where our standards, where our interventions are making a difference around that virtuous knowledge cycle. We haven't filled in all the gaps, and some of the things it's not for Global Alliance to do, but in working with others in combination, our goal is to try and create the interoperability that will make this viable. It doesn't mean we're not expecting everyone to share all their data all the time. but we want to make it as easy as possible for those who can and will share their data to do so in a responsible way. So just to repeat, this is not just about research, it is the combination, and it will not work. We won't achieve these goals unless we can bring these different sectors working together. I would be remiss if I didn't finish with an acknowledgement of the impact that COVID has had. I don't think there has been a stronger use case made in the last decade for the value and the importance, the critical nature of sharing health data across boundaries. We're seeing it on a daily basis. We're seeing the harm that can be done if we don't do it. And on more practical terms, it's given us greater engagement. Creative virtual meetings allowed more people from more countries to participate in our work. And it's also given us better tools for global collaboration. So I think that as difficult as this pandemic has been for the entire human population, there are some positives that can come out of it if we can go through the pandemic and make sure that we bring some of those learnings and so some of those imperatives for collaboration to the post-pandemic world. Thank you.